purpose of this film is to demonstrate the critical steps necessary to ensure that a surgical patient receives the correct surgical procedure. In this case, the patient has been transferred from the emergency department where he presented 6 hours earlier with intestinal obstruction. A flat plate of the abdomen showed multiple loops of distended small bowel. After decompression of the abdomen with nasogastric suction, rehydration with IV fluids, and potassium chloride replacement, the patient was prepared by the emergency medicine and surgical teams for an exploratory laparotomy, lysis of adhesions, and possible small bowel resection.
Good afternoon. I'm Rob Carducci. I'm one of the surgical nurses that's part of the surgical team that will be taking care of you today. Are you Noel Eldridge?
Yes.
Are your last four 2226?
Yep.
That was incorrect. Many adverse events due to patient misidentification have occurred when healthcare personnel have provided patients with identifying information and asked for their confirmation. Anxiety, distractions, cultural differences, and language barriers may interfere with a patient's understanding of questions asked of him or her just prior to undergoing a surgical procedure. Now let's see the correct way to identify a surgical patient.
Good afternoon. I'm Rob Carducci, one of the surgical nurses that's part of the operating room team that's going to be taking care of you today.
Hi.
Would you please state your name, social security number, and date of birth, please?
I went through all that in the emergency room. Don't you have some paperwork with my name on it?
Yes, I do, but we want you to identify yourself just to be absolutely certain. We sometimes have patients in here with very similar names. We don't want to perform a procedure on the wrong patient.
Has that actually happened?
Well, yes, it's happened in all the best hospitals in America. It's much safer for you to state your name and other identifying information to me yourself rather than for us to ask you to confirm what we say.
Okay, my name's Noel Eldridge. My birthday is April 10, 19...
Active patient identification is a critical element in patient safety for the prevention of patient misidentification in the operating room. This concept means that the patient, not healthcare personnel, takes an active role in his or her self-identification by stating full name, full social security number, or birth date.
Yes, Mr. Eldridge, that's all I need, and it matches what I have on our documentation in the computer and on your wristband. Now I'm reviewing your surgical consent form. Would you mind stating for me in your own words what operation you'll be undergoing today?
Well, the way Dr. Alba described it, my intestines are blocked up from my first operation in 1991.
Okay, so what is Dr. Alba planning to do?
He's going to go back into my guts and cut away the scar tissue adhesions, and he might have taken out part of my small intestines.
Okay, and did he say you might need a blood transfusion during this procedure?
Yeah.
Okay, Mr. Eldridge, do you have any questions?
Yeah, when is this going to happen?
We're setting up in the operating room right now. It shouldn't be much longer. Dr. Alba will be by to see you and to mark the surgical site.
Okay.
I'll see you in the OR in a few minutes, okay?
Okay, thanks.
Good afternoon, sir. I'm Dr. Shinek. I'll be your anesthesiologist today. Would you mind stating your name and your social security number, please?
My name's Noel Eldridge.
In greeting her
And, my
patient,
social security-
anesthesiologist Sal Shanak asked the patient to identify himself with his name and social security number or birth date. She verifies what he is saying with the information inscribed on his wristband. She will verify the patient's relevant medical history and the planned operative procedure. Sal also explains that the patient will need a nasogastric tube to empty the contents of his stomach before he goes to sleep, and she describes what he can expect when he is anesthetized and when he recovers from general anesthesia. After completing his own active patient identification, the surgeon Dan Albo greets the patient.
Hello again, Mr. Eldridge. Are you feeling any better since I last saw you in the ER a few hours ago? How is the pain?
I'm doing okay, Dr. Alba, but I'm getting worried about the time and my blocked intestines.
I understand. No worries. We'll be taking care of this shortly and you will be fine. I'm going to be marking the surgical site next where we're going to be placing our incision.
Marking the surgical site by the surgeon where the skin incision will be made is the third critical step to ensuring the correct surgical procedure. This task cannot be delegated to anyone but the operating surgeon to protect the safety of the surgical patient. The operating surgeon is the attending surgeon, the surgical resident, or the surgical fellow who will be starting the surgical procedure. It is essential that the marking pen used to mark the surgical site will leave a mark on the skin that cannot be removed when the surgical nurse subsequently preps the surgical site in the OR. The surgical site must also be marked in close proximity to the skin incision area so that it will be visible in the surgical field after prep and draping. It is important to remember for procedures that involve the right or left side of the body that only the side of the surgical procedure is marked. The side opposite the procedure should never be marked. Please note how the surgical site should be marked on some of the more challenging surgical procedures that have been associated with wrong site, wrong side, or wrong surgical procedures in the operating room or outside of the operating room. For surgical procedures involving sensitive areas of the body, such as the perineum, or for endoscopic procedures through the oral cavity or anus, or dental procedures, or transcutaneous procedures, a special purpose wristband can be applied instead of a skin marking. Such a wristband should indicate the planned procedure, including the surgical site and laterality, if the side of the body for the site is relevant. Knee arthroscopy, marking not on the thigh, but on the patella so the marking is visible in the surgical field. Hip replacement. Cataract extraction, marking not on the forehead, but just lateral to the lateral canthus of the eye to be visible in the surgical field. CT scan guided fine needle biopsy of the lung requiring a special purposed wristband. Radical nephrectomy, transurethral resection of the prostate requiring a special purposed wristband. Lumbar laminectomy, marking with the surgeon's initials at the skin incision site is followed by insertion of a spinal needle at the correct level while the patient is under local or general anesthesia. This is used as an anatomic reference guide during the surgical procedure. Dental extraction requiring special purposed wristband. Two professionals view the dental films together to identify the correct teeth for extraction. These teeth are checked off on a numerical dental map.
Okay, why don't you repeat that to me?
Yes, sir. 2,
Okay.
7.
Laparoscopic hemicolectomy, coronary artery bypass graft procedure. Both of these last two examples involve midline incisions. Midline incisions must always be marked to ensure the correct procedure will be conducted on the correct patient.
So how long will the operation take?
Oh, it should take a couple hours. It could be more. It really depends on how dense the scar tissue is inside your abdomen.
Okay, Doc, thanks.
No problem. I will see you in the OR shortly.
The surgical team has completed their preparation for the surgical procedure planned for our patient. The scene opens as the patient, Noel Eldridge, is being transported into the OR suite. In this case, Rob stayed with the patient after his patient identification in the pre-op holding area. If Rob was unable to stay with the patient, the active patient identification must be repeated by the surgical nurse who replaced him. That nurse would then accompany the patient to the OR suite.
Mr. Eldridge, I'm scanning your armband to make sure that you're in the right place for your procedure today.
Scanning the patient's wristband is the first step in the barcode matching of the patient with a blood product that has been prepared for that patient. If blood is required during the surgical procedure, the wristband is often covered by surgical drapes and unavailable for scanning. So scanning prior to the start of the procedure may obviate that problem.
Hi, Mr. Eldridge. I'll be giving you the anesthetic and keeping an eye on you during your procedure. We have met earlier in the holding area.
Right, okay.
Hi, Mr. Eldridge. I'm Dr. Berger. I'm going to be helping Dr. Albo during your surgery today.
Hi, everyone.
Hey, Dr. Albo.
Hi, Mr. Eldridge. We're going to get started here soon. We'll take good care of you through the case. You'll be up in the recovery room before you know it.
Okay, thank you.
Okay, everyone, let's do our preoperative briefing before we get started.
The surgical team gathers for a preoperative briefing guided by a checklist that has been standardized for the general surgery service. The team will go over their checklist for several minutes to discuss the planned surgical procedure, including any needs for equipment, special instruments, blood products, intravenous drugs, additional personnel, radiographs, disposition postoperatively, or other identifiable needs of the procedure. The team is now gathered around the patient ready to conduct their surgical timeout.
Are we ready to do our surgical timeout?
Yes, Rob, let's go ahead and get started. Sal, is that okay with you?
Sure.
Mr. Eldridge, we're going to go over our final preoperative checklist before we get started here.
Okay, Doc.
Okay, I have Noel Eldridge.
Rob and Dr. Albo begin by verifying the patient's name, full Social Security number, and birth date.
Yes, that's correct, Rob.
I agree.
Is the surgical site marked?
Yes, the site is marked on the midline of the abdomen with Dr. Albo's initials.
I confirm that.
Okay, the planned procedure is exploratory laparotomy, lysis of adhesions, possible small bowel resection.
Yes, Rob, that's correct.
I agree, that's what I have.
I take it there are no implants planned for this case. Is that right, Dr. Albo?
Well, Rob, we may be inserting some separate film prior to closure of the abdominal wound in an effort to prevent scar formation in the future.
Okay, we have sheets of separate film available in the room. Well, that concludes our timeout. Dr. Albo, would you and Dr. Berger confirm the images that will be used during this case?
Certainly, Rob.
Hey, Dr. Albo, these are Mr. Eldridge's films. As you can see, he has multiple dilated loops of small bowel. Certainly looks like a small bowel obstruction.
Yep, I agree, David. Let's get it started then.
The surgical timeout can be done before anesthetic induction, as it was done here, or after anesthetic induction, and after surgical prep and drape. If done before induction, the surgical team must not leave the immediate area of the OR suite to perform tasks unrelated to this patient. Advantages of doing the timeout before induction are: 1. The patient could participate in confirming procedure site, side, etc. 2. All preparations for the procedure, including positioning, can be modified prior to anesthetic induction. And 3. Wrong-sided nerve blocks are much less likely. An advantage to doing the timeout after surgical prep and drape is that all members of the surgical team are more likely to be scrubbed in the surgical field and less likely to be focused on other matters not relevant to this patient. The following is an example of conducting a surgical timeout with the team scrubbed in the surgical field just prior to making the skin incision.
Okay, Rob, let's go ahead and get the timeout done.
Right, I'll just run through our checklist, starting with our patient, Mr. Noel Eldridge.
I'm looking at his wristband. I have patient Noel Eldridge, Social Security 103-66-22226, date of birth April 10, 1960.
That's right. I have the procedure as exploratory laparotomy, lysis of adhesions, and possible small bowel resection.
The surgical site is marked with Dr. Albo's initials.
Okay, that's what I have on the IMED consent.
I can see that, Rob, and I confirm. I think we're good to go. Thank you.
Great.
The following critical steps must be included in the surgical timeout, with members of the surgical team confirming the following. 1. Accurate patient identity. 2. Accurate surgical consent, with agreement of the entire surgical team on the planned procedure. 3. Correct positioning of the patient on the OR table. 4. If required for the procedure, 2 members of the surgical team view relevant images together to verify the images are available, correct, properly labeled, properly presented, and represent the correct patient.
These are Mr. Eldridge's films. Certainly looks like a small bowel obstruction.
I agree, David. Let's get it started then.
5. The correct implant, if required. And 6. The correct surgical site is identified by a visible site marking after surgical prep and draping. The surgical team has been working for about 90 minutes. They have had some difficulty liberating the distal small bowel from dense adhesions in the floor of the pelvis. A segmental small bowel resection was required when they encountered a devitalized loop of ileum. At present, they are completing their end-to-end enteric anastomosis. Scrub nurse Cindy Gorbea has reached the end of her shift and must hand off her responsibilities to her colleague, Amy Carmack, who is giving her permanent relief. Cindy will conduct an SBAR handoff with Amy before turning over her scrub nurse responsibilities. SBAR, Situation, Background, Assessment, and Recommendation, is a logical, standardized method of transferring responsibilities between scrub nurses during a surgical procedure.
This is Mr. Eldridge, who came in last night with intestinal obstruction. He had a lot of adhesions with a segment of small bowel trapped in the pelvis. They had to remove some small bowel, and they are now completing their anastomosis.
Scissors.
Scissors.
Thank you.
Okay, so what's next here?
3OPDS, please.
3OPDS. Well, they're doing the small bowel anastomosis, and I think most of the adhesions have been taken down, so we're moving along. I'm guessing we should be closing in the next 30 to 45 minutes or so.
Right, do we have what we need for closure?
Yeah, he likes interrupted O-proline on the fascia, which I have on the back table, and also the stapler for the skin. Everything is here in the back table.
It's all there.
Dr. Berger, Amy is here to relieve me. Is this a good time for us to switch?
Hi, Amy. Sure, go ahead.
Amy, let's do our count. Dr. Berger, before you close, please do a wound exploration to make sure all the labs are out.
Okay.
Okay, Amy, we're gonna go ahead and start the needle count. We're gonna start on the field first. There's 1, 2, 3.
Cindy and Amy do their sponge and needle counts together before Cindy turns over her scrub nurse responsibilities to Amy.
Is that correct, Rob?
15 is correct.
I see 15.
Dr. Berger, Amy is here to relieve me now. Thank you, Amy.
Mayo scissors.
A permanent or temporary handoff between scrub nurses during a surgical procedure must be done efficiently and seamlessly to exchange the critical information necessary for maintaining the flow of the operation. S-bar is a logical and efficient way to organize this transition while maintaining the continuity of the procedure. The surgical team has completed the procedure and they are preparing to close the surgical wound. The scrub nurse is counting sponges, sharps, and instruments with the circulating nurse to verify that all are accounted for prior to wound closure. Based upon the VA directive, Prevention of Retained Surgical Items, as well as guidelines from the Association of Perioperative Nursing, or AORN, counting practices should be standardized and conducted in the same way in all hospital operating rooms or surgical centers. Amy and Rob are counting sponges, sharps, and instruments together to reconcile their current counts with the counts from the beginning of the procedure. During the counting of instruments, Rob is following his count sheet that accompanied the instrument tray prepared by the Supplies, Processing, and Distribution Department, or SPD. When accounting for sponges, surgical nurses should use a method that is transparent for all surgical team members in the OR to see. Any additional instruments introduced to the surgical field during the course of the procedure should be added to the count sheet or listed on the whiteboard so each new item can be accounted for at the end of the procedure. While maintaining the flow of the operation, the surgical team cooperates with the scrub nurse and the circulating nurse to facilitate complete and accurate counting of all items on the surgical field.
I'm finishing up my wound exploration. I really think I got all the laps out of here. Do we have the separate film?
Yes, it's right here. Dr. Berger, please give Rob and I a minute to finish our closing count.
You know, we really need to get this guy out of here.
Okay. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5.
Here's 1, 2, 3, 4, 5. 1, 2, 3, and 4. Dr. Berger, Dr. Albo, we're missing a lap pad. Would you mind checking the field, make sure it's not hiding somewhere?
Rob, I can't believe this. There seems to be an epidemic of missing labs in this OR lately.
Rob, have you looked everywhere? Did you check the floor, the kick bucket, the trash? Take a look again. I'm sure you'll find it. Amy, can I have the fascial closure suture, please?
Dr. Berger, do you think you could look in the wound for the lap pad before you start closing?
She's right, Dr. Berger. We've done 2 counts and still have a missing lap. I've scoured this room and haven't been able to come up with it.
I'll tell you what, David, they're right. Let's check the wound again.
Okay, Amy. Give me the retractor. We'll take another look.
When the scrub nurse reports a missing surgical item due to an unreconciled count, the first responsibility of the surgeon is to stop wound closure and perform a methodical wound exploration. Rather than just a quick look, the surgeon must carefully examine the wound with a visual inspection and a tactile exploration in an effort to recover the missing item, which is a laparotomy pad in this case.
Dr. Albo, I've looked everywhere and I can't find a lap pad. Now what?
Well, I'll tell you what, David, we have to get an X-ray of his abdomen. That's our protocol.
I've already called radiology. The tech said he'd be up in about 10 minutes.
10 minutes? I have patients in clinic and consults up the wazoo. I don't have time for this.
Well, David, our first responsibility is to make sure that this patient leaves this OR tonight without a lap in his belly. Everything else will have to wait.
An intraoperative radiograph is required at the end of the surgical procedure prior to wound closure for one of two reasons. 1. Incorrect count of a surgical item. This means that the final count is not the same as the initial count. Or 2. When an instrument count has not been performed on the surgical field. An exception to the requirement for counting instruments would be for surgical procedures in which a retained surgical instrument is virtually impossible. Virtually impossible does not mean unlikely, because a retained surgical instrument is always unlikely. An example of a procedure that would be virtually impossible would be a skin biopsy. For medical reasons, the surgeon may decide to forego the counting of instruments and/or the intraoperative radiograph, which must be documented in the medical record. A portable radiograph of the abdomen was taken by the radiology technician and reported by the radiologist to the surgical team within 30 minutes of the request from the OR. A radiologist must review and report the findings of the intraoperative radiograph to a member of the surgical team within 30 minutes of the request. If the surgical procedure is done after hours, on a weekend, or on a holiday, the report must be made to the surgeon within 16 hours of the procedure termination.
David, they think they see something suspicious on the midline. They're not sure, though, and they would like to get another x-ray, this time an oblique view. Rob, could you do me a favor? Could you call the radiology tech back in and ask him that we need to get another x-ray of the abdomen, this time an oblique view, please?
Sure.
The oblique film has been taken. Dr. Albo has just finished a phone call with the radiologist, who identified a retained laparotomy pad in the midline of the abdominal cavity.
Let's see the oblique film, Rob. Ah, there it is.
I can see it now. The oblique view is not subtle. It's definitely in the midline. Okay, David, let's find it and get it over with.
Okay, Amy, can I have a Richardson retractor?
Richardson retractor.
Make it 2, please.
Richardson retractor.
Thank you.
Yep, here it is. It was rolled up like a ball between two loops of small bowel. That's probably why I couldn't feel it.
Here it is.
Excellent.
All surgical items used in the surgical field should be detectable by radiograph when available and whenever possible. Such surgical items commonly used in the operative field are 4x4 sponge, 4x8 sponge, laparotomy pad, surgical towel with radiopaque marking. The radiopaque marking in the surgical towel should be evident to the surgical team. A blue towel with blue radiopaque tail, a white towel with radiopaque blue tail, a white towel with radiopaque marking in the side. It is generally not recommended as good practice to use 4x4 or 4x8 sponges for surgical procedures in large body cavities, such as the chest and the abdomen.
Well, finally. Are we okay now, Rob?
Yep, we're good.
Okay, David, I'm out of here. Call me if you need me, okay?
Dr. Albo, could we do a quick debriefing of this case before you leave? We can do it while they're closing, and it'll only take a couple of minutes.
Sure thing, Rob. You're right.
To prevent the retention of surgical items in operative procedures, the following steps must be implemented. 1. Consistent implementation of standardized practices for counting sponges, sharps, and instruments. Guidance from the VA Directive Prevention of Retained Surgical Items is recommended. 2. A methodical wound exploration using visual and tactile senses prior to wound closure, and this should be repeated whenever a surgical item is missing. 3. All items used on the surgical field should be detectable by radiograph when available at all times. 4. An intraoperative radiograph must be taken in timely fashion when a surgical item is missing with an unreconciled count or when instruments are not counted. And 5. An intraoperative radiograph must be reported by the radiologist to a member of the surgical team, person to person, within 30 minutes of the request.